All right, now we're looking at the appendicular skeleton. In this case, we're looking at the shoulder joint. And you can see the clavicle and the acromion process and the scapula meet to create a housing for the ball and socket. You can see the humeral head has that kind of ball shape towards the end. And it's going to fit into that process, which allows it the greatest range of movement. There's nothing really to impinge against it, and we can get a significant degree of movement, be it 180 degrees and plus, from most different viewpoints. You can look a little deeper into the structures on the right and kind of see where the processes are and where the bones meet, and then where some of these muscles and tendons get their names from. Okay, so now we're looking at the upper extremity. So we're looking at the triceps, tri being 3, so there's 3 heads to the tricep, right? And then biceps being 2, that's 2 muscles in the anterior upper arm that causes adduction. Or we can look at the elbow, and as you're looking down, I want you to pay attention to the medial condyle. That is what protects the radial nerve, or if you strike it the right way, the funny bone. And so if you actually tap in the right section there, you can hit the nerve that runs through that condyle process, and that's what causes that intense pain that runs down the hand from that point. Looking at the arm again, you can see the ulna and the radius and the radial styloid. So those are where everything meets into the carpals. So when people have metacarpal issues or carpal tunnel syndrome, that is a stiffening of that joint with a loss of space for the tendons to run through, causing a lot of pain. As you can see, the base of the hand as it meets the wrist gets pretty complex with those small cubical bones, the carpals. And as those tend to degenerate or end up with other areas of inflammation, we can see how that would really create some really big problems for those tendons and nerves. All right, now we're looking at the pelvic girdle or the pelvis, right? And as you can see in the picture, you can see the descending aorta and the inferior cava running really basically on top of the spine. I mean, it's right on either side of the spine as it runs down, and that's obviously by design. We want to make sure that we're protecting those great vessels, because any kind of tear or opening in those would cause almost an immediate death, and so they're generally placed somewhere where they can be protected by bone. As it kind of comes into the pelvic girdle, we see it bifurcates, right, which means that it's splitting and it's going to go into each leg. So you have a femoral artery and then a femoral vein in each leg, those being protected again by the pelvic girdle. And as it comes out kind of by the pubis, you have a momentary lapse of protection before it dives deep back into the quadriceps. The pelvis is 3 joints, and it supports all the weight of the body, well, I should say of most of the body, as you're standing or walking. And now we're looking at the lower extremity. You can see the pelvis again, right? And there's that ball and socket for the hip, which gives us the greatest range of motion. And that's how we can articulate and rotate feet out or in, or move legs as according to help with mobility. The femur is the largest bone in the human body, and is probably one of the more structurally significant bones in the body. It can take the most amount of force. So when we tend to see any kind of femur fractures or destructive forces against the femur, we can pretty reasonably suspect that it was a high velocity or a very high energy event. The tibia and the fibula make up the lower leg, and those are going to go into the tarsals, which make up the ankle, and the foot and the hand have very similar structures in regards to how they're laid out. Okay, now we're back to the knee. As we were talking about, we have those ligaments and tendons, and as you can see across the front, the patellar tendons there, right? We have quadriceps femoris tendon. That's as it comes across into the knee, and then it becomes a patellar ligament after it makes it past the patella, right? So there's quite a complex amount of soft tissue that is pretty tough, and then if it becomes injured, it's really difficult for it to heal because tendons and ligaments have very reduced blood flow, and so when they do become injured, they take a significant amount of time to actually heal, usually requiring some kind of a surgery. Again, the ankle and the foot, right? That's a complex process there. You can see the Achilles tendon across the back attaching to the heel. So that calf to the back of the heel, making it a tendon because it's muscle to bone. And then if you look along the white sections, as in the lower picture, you can see a lot of the ligaments that are tying the structures from the foot into the ankle. So bones have several functions. It's, again, to provide form to the human body, which gives us the ability to have some kind of mobility, right? Their bigger structures are to protect internal organs and blood vessels, right? So with muscles and bones, we can get that kind of movement because we're using the muscle to create movement across the bone when it moves bones in a general direction as the muscle flexes or extends. Bones are primarily made of calcium, and most people don't realize this, but your skeletal system actually goes through a complete remodeling about once every 10 years. Every bit of calcium has been absorbed and then redeposited with obviously new calcium in the body. So this is an ongoing kind of replacement to make sure that the structures are utilized correctly. And as you apply force to certain parts of the body, the bones become denser and stronger. And so as that system is built, it wants to make sure that it actually adds the correct bone density and remodeling. Okay, so now we're talking specifically about musculoskeletal system. Again, it's the body's form, upright posture, and your movement. There are over 600 muscles in the human body that allow for all of the movement that we're capable of. And the type of muscle found against the skeletal is skeletal muscle. Smooth muscle is all of the small structures that are in the vascular system and the intestines. And those smooth muscles are what help create blood return or peristalsis in the case of trying to move fecal matter through the intestinal circuit so that we can excrete waste. Cardiac muscle is its own specific type of cell, and it is only found in the heart. So when we're looking at the types of muscle, cardiac, again, found only in the heart. It's specially adapted, right? It is fed oxygen and nutrients first. As the cardiac contractility happens, the first bit of blood that goes into the body is actually refed to the heart so that it can constantly have the ability to contract. It does not fatigue, obviously, like skeletal muscle, and rightly so. And then again, skeletal muscle, if you're looking at that, that is to create movement along all of the skeletal structures. And then smooth muscle, again, is in the blood vessels in the intestines, which is helping to create some kind of fluid or other matter shift throughout the body. Okay, so contraction and relaxation make movement possible, and just try to remember that every time you flex one muscle, its opposing muscle is relaxing and going into a stretch. A byproduct of movement is heat, right? So when we're burning glucose, there is a thermogenic effect, and glucose is what's fueling those cells to be able to contract and fire. And so anytime that we have any of that, we're always going to have that byproduct of heat. There's no free lunch, so to speak, and all energy is going to have to be transferred. Most often, most energy is transferred into heat. Okay, so now we're going to talk about the respiratory system and its anatomy. And we're going to start with the nose, the mouth, the throat, the larynx, the trachea and the bronchi, the bronchioles, lungs, diaphragm, muscles of the chest wall, and accessory muscles of breathing. So if we're looking at this is going to be a superior to inferior kind of view. And we're looking at the nasopharynx, the nasal air passages, the pharynx, the oropharynx, the mouth, the epiglottis, the larynx, the apex of the lung. As you can remember, we were talking about that point or arc. And then on the right, we have the trachea. And then as we kind of dive in a little bit more, we're into the lower airway with the alveoli and the bronchioles and the main bronchi. And then the carina, which is the actual crest or point where the two bronchi meet and dive off into their own lung. And then we have the base of the lung and the diaphragm. If you look deeply at the picture on the right lower corner, one of the things I want to impress upon you guys and make sure that you remember is that only in the respiratory system is something completely flipped backwards as far as coloration, right? So pretty typically when we're looking at the cardiovascular system, anything that's blue is considered a vein. But in reality, a vein is anything that's leading back to the heart, and an artery is anything leaving the heart. So as blood comes into the heart, it's going to have the blue color, right, from the vena cava. And when it leaves the heart, the pulmonary artery is deoxygenated blood, so it's going to be blue. So if you're looking at those small alveolar pockets, the blue is the arterial side, and then the red is actually the venous side, as it's leaving the alveolar pockets and going back to the heart. So it's kind of confusing. You guys will see it on your test quite often. And you just have to remember in the pulmonary system, the colors are flipped so that you don't get confused on a vein and an artery. So now we're digging a little deeper into the upper airway, which is the anterior and at midline. And this is the nose, the mouth, the tongue, the jaw, and the oral cavity, the larynx and the pharynx. The pharynx is composed of the nasopharynx, the oropharynx, and the laryngeal pharynx, right? And these are all the large pockets of empty space, so to speak, in the skull and the throat. And the esophagus and the trachea are at the bottom of this. And these are the two structures that are going to either take food down through the core or air into the respiratory system. The epiglottis is, like we talked about in class, a piece of tissue that's basically structured at the base of the tongue. And as you swallow, the tongue moves back and the glottis folds over and covers the tracheal opening, preventing you from inhaling any liquid or food debris. This is also, like we talked about when we're dealing with airway issues, where we're using a supraglottic airway. We're actually performing some kind of a modified jaw thrust, if you want to call it that, where we're moving the tongue up out of the way. It's lifting the epiglottis, giving us a direct line of airflow from that airway into the respiratory system. Now, if we're in the lower airway, we're talking about, again, that Adam's apple, right? We're looking at the thyroid cartilage, and right below that is that cricoid cartilage, which is, again, what we would use for a a cric, right? We're looking for that membrane there. And then below the cricoid cartilage is the trachea, which is the large tube going into the thorax and turning into the bronchi. So the main stem bronchi divide into secondary and tertiary bronchi and eventually the bronchioles, right? So remember, secondary is the second, or the next subsection, tertiary being the third, and then each bronchiole divides into alveoli. And this happens rather quickly. You can see that the tubing gets smaller and smaller very quickly until we're basically into a very dense sponge-like kind of tissue. Lungs are the primary organs of breathing. The right lung contains 3 lobes. The left the left lung contains 2 lobes. And this is because the heart sits a little bit shifted to the left of midline, and so there's a little bit less room, and the lung does not have the extra lobe in regards to the space needed to encase the heart. If you look at the picture there, you can see the diaphragm is sitting up right up against the lower lobes of the lungs, and as that flexes, it's going to move distal or inferior in the body, and it's creating that negative pressure, which allows room air to rush into the lungs. The visceral pleura covers the lungs, and the parietal pleura lines the pleural cavity, which is what the lungs sit in. And the best way to kind of describe this is kind of like maybe like 2 layers of saran wrap. one covering the lungs and one kind of covering the chest cavity. And this allows for less friction between the lungs and the like the rib cage. We don't want any of that soft tissue rubbing against each other, creating inflammation or some kind of condition where we're actually causing any kind of scarring. So the body uses these pleural linings to allow that rubbing without the increased amount of friction. And so you guys will see in the book, it's going to say something about a pleural rub. And often students will ask, well, what does that sound like? And the easiest way for me to describe that is you rubbing your finger across a balloon, and that kind of squeaky noise that you're going to get is what we would consider a pleural rub. So the pleural space is a potential space that can be created, right? And so when we talk about like a pneumo, where we have an air pocket, that's a small pocket of air that's escaped from the lung into the a small pocket of air that's escaped from the lung into the actual chest cavity, and that's creating that collapse in the lung, right? So the pressure of air there getting in between those two pleural spaces, or I should say pleural linings, is going to cause the lung to collapse. So when we're talking again about that vascular system in the pulmonary system, deoxygenated blood is going to leave the right side of the heart via pulmonary arteries, right? And again, those are going to be blue because they're deoxygenated, but because it's leaving the heart, it is a artery. And then it will make its way into the lungs all the way to the alveolar pockets, where we're going to have the pulmonary capillaries. And then again, the venous side of the pulmonary system is going to be red, and it's coming back to the heart into the left side. The diaphragm again is the primary muscle of breathing. When we flex the diaphragm, it moves distal, which is going to create more space. This creates negative pressure. And again, it's not necessarily a vacuum. There's really no such thing as a vacuum. When you're breathing, you will create less pressure and the atmosphere rushes in to create balance. And so room air actually forces its way into your lungs when you create that flexation of the diaphragm. It is also the primary muscle that's dividing the pulmonary system from the GI system. And so there's a small sphincter that intestines and other things will kind of run through to get into that area, just because everything has to kind of come through the mouth and then make its way into the lower thoracic cavity. Some other muscles that they want to make sure that we know about are the intercostal, the abdominal, and the pectoral muscles. And these are all muscles of breathing. For the most part, they're not very active until we are actively trying to ventilate. Most of your breathing is a passive event. All right, physiology of the respiratory system, which is respiration, and that's the exchange of gases at the alveolar capillary membrane. And ventilation is the actual mechanical movement of air, right? So that's when I'm ventilating, that's me taking the breath. Respiration is the gas exchange where those gases meet. So you have two forms of respiration, right? We have pulmonary respiration, which is the gas exchange inside the alveolar pockets through that membrane. And then we have cellular respiration, which is where the gases again exchange at the cell into the blood. So the respiratory center, or the pons, is the center for breathing in the brainstem. And the CO2, or carbon dioxide levels in the blood, for creating the sensation of wanting to breathe. So when we're holding our breath and we get that burning sensation and that overwhelming urge to take that breath in, that is as carbon dioxide levels rise in the bloodstream. It trips those chemoreceptors and creates the urge to want to breathe. And it just takes a small amount of CO2. So you can quite literally train yourself to kind of withstand those small changes in CO2 in the bloodstream and resist the urge to breathe. But it's a chemical process that triggers the brain into doing what it needs to do for an involuntary reflex. So as we talk about those increased levels of CO2, people with significant respiratory problems might have what we call a hypoxic drive, and it's less sensitive in its ability to make you want to breathe. The breathing creating O2 levels in the blood as compared to the CO2 levels. The things that we want to make sure that we're aware of are respiratory acidosis versus metabolic acidosis. So when we're looking at this, you have respiratory and renal systems helping to maintain that acid-base balance. The respiratory system being the immediate trigger, the renal system or the body kind of taking a little bit longer to come online. And once they're triggered, those things will actually take quite a significant amount of time to kind of stabilize and get themselves back into a better balance of pH.